Great. Thank you for that fantastic discussion. We're going to switch gears now and go into an interactive panel discussion on immunizations for aging adults with HIV, titled What's New for the Old? And for this discussion, I'm going to be joined by a couple of panel members, Dr. Bedimo, who you've met, and Dr. Longenecker, who's at the University of Washington. Dr. Farhadian may join us shortly, although she was on the clinical. Oh, yep, she is there. Perfect. Dr. Farhadian, who's at Yale Medical Center. And I will give the caveat that we aren't all vaccine experts by any means, so we are here to learn with Dr. Spach as well. Dr. Spach is the principal investigator and clinical director of Mountain West AIDS Education and Training Center, editor-in-chief and author for 5 federally funded education websites, including the National HIV Curriculum and the National HIV Prep Curriculum. He's received multiple teaching honors, including the HIV Clinical Educator Award, the Ryan White National AIDS Education and Training Center Award, the University of Washington Department of Medicine Paul Beeson Teaching Award, and the Marvin Turk Outstanding Teaching Award. And we are so happy to have him here to teach us today about vaccines to make sure that we are giving correct vaccines to our older patients with HIV. Dr. Spach, I will turn it over to you.
Great, Kristine. Did you want to say a word about the rest of the panelists, or do you want me to?
Just did the brief introduction. I think that is good.
Okay, so we also today, I think we're very well represented from all corners of the country here. 'Cause of course, we have you and Roger. We also have Chris Longenecker from University of Washington. We have Shelli, who represents Yale University, and then we have Colorado and we have Texas. So I think we've got all corners of the country. What we're going to do in this is try and have a little fun talking about some of the what's newer issues related to vaccines, but try to drill down on issues with vaccines that really impact people who are, 55 and older, 60 and older, 65 and older, and even some instances 70 and older. I do not have any financial relationships to disclose. These are the basic learning objectives that we hope you get out of this, which would be to implement and make sure you know about the new pneumococcal recommendations, including pneumococcal PCV 21, to describe the appropriate shingles vaccines in people who've previously gotten the older vaccine, the live vaccine, to list what the current guidelines and recommendations are for RSV vaccination in people with HIV, and last, try and summarize approaches to mpox vaccination in older persons who previously received smallpox. I just want to mention that vaccines are a little tricky because they don't really have generic names, and sometimes you can get very, very confused talking about, 4 different brands of vaccines that all have numerical numbers, and people don't actually know what you're talking about. So I personally never like to use trade names, but in some instances with vaccines, I think to keep things straight, trade names will come in just to make sure there's no confusion for the purpose of education and I think clinical fidelity here. These are the actual vaccines we're hoping to talk about. We're I think somewhat on a informal structure, in that we're going to try to really talk about pneumococcal vaccines, zoster, RSV, influenza, and mpox. If we have time, we're going to try and get into the panel's perceptions about some of the strategies about, when you vaccinate, when priority-wise, when you have like a new patient come in, you've got all these priorities that you have to do, some issues related to vaccine hesitancy, and maybe if we have time at the end, just a brief mention about meningococcal vaccine. Let's jump right in with pneumococcal vaccines. And this is one I picked first because I think it's a very high priority vaccine. I think it's super high priority in people over the age of 60. So here's a case. And this is also just sort of see what the audience is doing in their practice. So a 52-year-old woman comes in. She's newly diagnosed with HIV. Lab shows CD4 count of 484. She lives on the East Coast. What would you recommend in your clinic, in your practice, for what you would give for her pneumococcal vaccination? Would you give the PCV 15 and give a PPSV polysaccharide vaccine 23 8 weeks later? Would you give a PCV 20, one and done, or would you give a PCV 21, one and done? Let's see what people say. There's not a right answer here. Okay, so we see mostly 20 and 21. That's great. And PCV 21, for those of you who don't know, was fairly recently FDA approved. And I have a follow-up question that is very relevant for all of our vaccines. So the question I'm asking now, and pay special attention to this for the pre and post test here. So which one of these conjugate pneumococcal vaccines does not include pneumococcal serotype 4? Take a shot at that. See what people vote on this. Okay, so we've got a pretty wide distribution. We've got a nice ability and chance to have a learning moment here. The one that does not contain serotype 4 is ironically the one with the most serotypes, PCV21. So I'm going to turn to our panel in just a second to talk about what the significance of that is and how that might impact your clinical practice. But PCV21 is the one that does not have serotype 4. Now, when we look at just the sort of serotypes, I'll just take 1 minute and go over this and then turn to the panel. Very important when you look at these visually, you can see that PCV 15 and 20 are almost the same, except PCV 20 just has more than PCV 15. So there's really no difference or advantage of PCV 15 if you look at the serotypes. They are very similar vaccines. It's just PCV 20 is 15 and more, 5 more strains. However, when you look at 21, notice that that is not visually a matching up with 20 or 15 at all. The concept for you, if you look at this, is PCV 21 is a very different pneumococcal vaccine with very different serotypes. So if in your mind you were thinking, I'm giving PCV 20 plus 1 more, that is not accurate. PCV 21 is a very different vaccine. And what's different, that's most important probably, is that pneumococcal serotype 4 is not in PCV 21. So let me turn to Roger and tell me, what is the significance of this not having 4? What are you doing in your practice in Texas? And what do you think about, the current recommendations for pneumococcal vaccines?
Yeah, I'm scratching my head as the researchers who managed to put a hole in the newest vaccine. Personally, I have liked the one and done that started being the practice with PCV20. Because even if people know that there's some coverage with PCV13, PPSV23, that coming back, if you look in clinical practice, is a risk for falling out. So one and done is great. And the fact that serotype 4 is not included PCV21 makes me concerned in places where it's prevalent. And that is what I think the new guidelines will say. If that 4 is prevalent in a setting, then this is probably not the best vaccine for you, regardless of how the pharmaceutical representatives have wooed you. And the way I personally think of it is we're a little far from that area, the Four Corners area. That's the way I would like to think of it: Utah, Colorado, Arizona, New Mexico. So since we're a little east of it, it's probably not an issue for us.
Sounds great. Shelli or Kristine, are you doing anything different in your practice? You predominantly, like Roger, using PCV20? Are you embracing more PCV21, say, for example, being on the East Coast, Shelli?
Yeah, we're on the East Coast. Our clinic stocks PCV21. As far as I know, serotype 4 is not really an issue in our part of the country. And PCV21 does cover the most common strains. That's why it was serotypes, excuse me. That's why it was developed, right, to be superior based on the most recent epidemiologic data. So for us, it's a pretty straightforward decision to use PCV21. I would imagine it may be different for Kristine in Colorado.
Yeah, I can't even order PCV21. We only have 20 in our ordering in Epic, and that's all we stock in clinic. So we only give 20, but I'm in the Four Corners region, so we don't venture into the 21 territory. So
Great. I think this really hits the highlights. I mean, I think all of us, as Roger said, we're really loving this one and done. So I think if you look at what the audience said, what we're all kind of coming up with, very few people, I think, are really doing the 2-shot, the PCV15 followed by the polysaccharide. It's just not as convenient. Like you say, Roger, having people come back 8 weeks later. What Roger is pointing out is that the guidelines do make this point. If serotype 4 is greater than 30% in your region, then you really want to stop and think, do you really want to use? So I think the panelists have really laid this out very nicely that, where we want to think about not using PCV21 is just like Roger saying, the four corner states That's an area where there's actually significant high percentage of invasive pneumococcal strains or the pneumococcal serotype 4. And then some of these other areas like where Chris and I are in Washington and Oregon and Alaska, or people maybe more likely to move to these areas, you can see that that's where. So there isn't a right answer now what to use to pneumococcal vaccine, but I think you should at least have a reason or logic for what you're using in your area. So that hit all of the highlights. Anybody want to make any other comments about that before moving to some of sort of the age-related people 65 and older? Okay, great. I think that hit really the highlights. Now, what I want to get into is what about your aging population? Many of these people, we were, incredibly diligent. We did all those complicated, follow-up 5-year, get the PCV13. We did the follow-up vaccines. We got them all vaccinated. And now they're 65 or they're older than 65. What do we do now in terms of any more vaccines now that we have these? So now the question I'm asking here is that a 70-year-old man comes in, he completed all the previous series and got a dose of the polysaccharide vaccine at age 65 per the guidelines, CDC recommendations. The medical provider did everything right. So now the question is, given that we have these better new vaccines, would you give him any additional pneumococcal vaccine? So Kristine, I'll turn to you. In your practice, what would you do? And again, not a right answer here, but I'm really interested to see what panelists would be doing here.
Yeah, I would offer him a 20, now that it's been 5 years since his initial one. I do have a question though, like if he's 69 and he asks for a booster and says, I'm really concerned about pneumonia, is it wrong to give him a 20 earlier since we know it has better coverage? And I think along the vaccine world currently too, he's concerned his insurance might not cover it later. So is it wrong to give a vaccine a year early too? I pose that question back to you.
I love this question. And I would say in the clinic, this comes up most often when I'm with the residents and fellows. Well, why can't we just give it a year or two early? So there was somewhat of an arbitrary 5-year pause that was recommended between conjugate vaccines and someone in this setting. So the CDC actually recommends to wait 5 years. But I actually don't think there's anything magic about that. And I think if you were at year 4 out and you had an opportunity to immunize this person and they were a person with HIV, I definitely think that's a reasonable thing to do. I do want to mention the guidelines say 5 years, but I think looking at the safety of this vaccine overall, there is some concern that if you bunch them too close together, you may not get as robust an immune response. But I think 4 years versus 5 years, I can't, in my mind, see a big difference. And Roger, I don't know if you have a strong opinion about that or want to take a different stand.
No, I don't. I agree with you. I think that it's good to have these arbitrary timelines, but it's also important to see why we have them and have flexibility around it.
I love that. Okay, now, so here's what the question really is. They went through, they got all this, and as you can see, as Roger said earlier, one and done is a lot easier than what we used to do. So in contrast to most things in clinical practice where I think they've made our life more complicated with guidelines or new innovations, this is one of the things that dramatically simplified. It's so easy now to vaccinate someone with pneumococcal disease by just giving them essentially one shot PCV 20 or 21. But this question is answered in the guidelines in ACIP, where they basically say exactly as Kristine outlined. You can offer it, and if you're going to offer it, you ideally wait at least 5 years. It's considered optional, and it would be PCV 20 or 21 that you could do, and then you would be done. So I think for those of you that do have an aging population that you're managing, this is something that you can offer. I don't think there's any downside. I think these are very safe vaccines. So I personally think somebody, for example, who's already been through all of these, 70 years of age, very reasonable or close to that age to give them that final dose, at least to offer it or discuss it. So that's kind of where we're at with the older person. Any other comments before we leave pneumococcal disease? Chris, any special cardiovascular issues with pneumococcal disease? I know we're going to get to that with some of the respiratory viruses.
No, just to say that people with cardiovascular disease are at risk of cardiovascular complications of pneumococcal disease, as with all the other respiratory viruses as well. So we'll talk more about that in a bit.
Yeah, and one thing I do want to do is I really want to make sure we turn back to Chris to comment as the cardiologist on the panel. We do all these vaccines to prevent invasive disease. But of course, one of the things that people die from the flu and these other things are cardiovascular complications with one of these viruses. I think it's important to get that cardiovascular perspective. Okay, let's look at zoster vaccine. What do you think about this one? 59-year-old man with HIV recently moved. He's now seen for a visit in the clinic. On review of the vaccine history, he had received one dose of the shingles vaccine, the Zostavax, in 2016. He was told that that shingles vaccine had live virus, which is true. Now, what would you recommend now for this individual? Would you say he got appropriate vaccination? We don't need any more, no further vaccination. Would you give him one dose of the newer inactivated vaccine, Shingrix, or give two doses of the newer zoster vaccine, the Shingrix, spacing them 2 to 6 months apart? What do people like here? Okay, great. I think our audience is spot on this. The recommendations have been very clear about this, that you can re-immunize people. And I'm going to turn to Shelli because I know you have a special interest in zoster vaccine in the aging population. Just to summarize again what the guidelines say, that if someone has previously had a zoster vaccine, they can receive this. And I think the question is, sort of how aggressive are you, Shelli, in your practice for vaccinating people against zoster? I know we used to just do this for people 50 and older. We're doing it for, younger patients now. Tell me a little bit about what your perspective is on zoster vaccine and in the aging.
This is an incredible vaccine because it actually helps prevent not one, but two, and maybe even three conditions. And so that's kind of how I like to frame it to people. So, first of all, highly effective for preventing shingles, which is top of mind. And of course, that's what it's designed for. Shingles being an incredibly painful, uncomfortable illness. So, if we can avoid that, that's great. I'm also really worried about post-herpetic neuralgia. So I see that in a bunch of my patients. I'm sure you guys do too. That is a very difficult condition with few treatment options, often refractory to treatment. And so if we can give a vaccine to prevent post-herpetic neuralgia, fantastic. And I think you're going to get into this, but we're starting to see, I think, really high quality research coming out to suggest that we may even be able to use this vaccine to improve brain health, or in other words, reduce the risk of developing dementia. So lots of reasons to do the shingles vaccine. Unfortunately, it can be a little bit more difficult to give because I know we don't stock it in our clinic. We have to send people out to a pharmacy to get it, which is a bit of a bummer. But definitely, this is something I talk about with all of my patients, my older adults.
Great. And I think I do want to circle back to you in just a minute, but maybe I'll turn to Kristine now and just ask you a question. If someone had a very recent episode of zoster, first of all, can you give them the shingles vaccine? And if so, how long would you wait after acute episode of zoster before giving them the shingles vaccine?
Yes, you can give it if they've had recent zoster. I believe you want to wait kind of until lesions are crusted over, they're not on acyclovir, some sort of antiviral anymore, and probably at least a few weeks after. But I don't know that for sure.
Yeah, no, and I think the concept for the audience is that you kind of have competing immune responses. If you've got an active natural immune response going on in response to natural infection, you just sort of want to wait that to die down. So we do, as you said, wait for lesions to resolve. You just don't want to give it the day they come in with acute shingles. I think that's a mistake. Now, one of the questions is, how do you counsel people on side effects? Either if any of you want to take this, do you think, do you see people in your practice who go, whoa, that one was a doozy. That vaccine, was a little bit more than the flu shot. And I didn't know that up front. So who wants to comment on that? Sort of what they see with their patients.
Tell my patients that this is a Friday vaccine.
Right.
Yeah.
And because, of course, you cannot predict the reactogenicity in a specific patient, but it's so much more reactogenic than others that it's important to predict and to plan for at least a day off if that does happen.
I love that you said that. And I really like that a lot of pharmacies offer it now, because a lot of my patients, I don't know that I would get this on Thursday afternoon and go to work Friday morning. It's sometimes people really do get. Shelly, what's been your experience with this?
That same, I found him maybe over counseling people and saying, this one might knock you out. And they usually come back and say it wasn't as bad as you said it would be. But I love the way Rajay framed it as a Friday vaccine, and I'm going to use that from
Yeah.
now on.
That's so great. I love that. You know, I mean, the other thing is we're going to talk a little bit about things we don't usually give together. I'll just say in our practice, when the residents are, rattling off and they're, give the person 10 vaccines at one visit, I usually go, don't give this and COVID on the same day because, I think people, number one, they may get enhanced side effects, but number two, they may blame the COVID vaccine, severity of post-vaccination sort of myalgias and everything they may blame the vaccine on COVID. One of the questions that I did ask was, whether or not you can give the zoster vaccine to someone who previously got, and the data is very good. This is just a study that showed very good responses in people in very good immunogenicity in people who had been previously vaccinated. So essentially, not really a big difference in people who've never been vaccinated before. So I think the take home point from this is, yes, if someone had the old vaccine, the newer vaccine, as Roger says, is much more immunogenic. It's much more reactogenic. People get a better response. There's better outcomes with this. So go ahead and give them this. And I'm going to turn back to you, Shelly, because I think this is fascinating, and this is not just, sort of, tabloid magazine stuff. This is now starting to become much more mainstream discussion. And I just grabbed this screenshot because this is from a Harvard news setting. And tell me your perspective on this, and dive a little bit deeper into this for us because I think it's really interesting about
I
the
think
potential
it's,
for
yeah,
zoster vaccine.
super compelling. I mean, so to be clear, there was no randomized controlled trial, which would, of course, be the gold standard to give one group of people a vaccine, don't give it to the other, and then follow and see who develops dementia. That did not happen. But what we have instead, and this is just one of the high quality studies that's been published, and this was just in the last year, is a natural experiment. So in Wales, people born before a certain date were eligible for the vaccine. People born after that date were not eligible. Oh, excuse me. And so what you could see is really based on birthdays being one day apart, which group developed dementia and at what rate. And just by being eligible for having the zoster vaccine, significantly reduced the risk of developing dementia over 7 years that folks were followed in this study. So just to be clear, again, it's not a randomized controlled trial, but it's really high quality epidemiologic evidence that's now been carried out in several countries, all coming to really similar conclusions. So we can't say for sure that the zoster vaccine prevents dementia, but it's certainly suggestive, and biologically it makes sense to me.
Yeah.
Thinking about neuroinflammation and immune reactions to a chronic presence of a chronic virus, I think it makes a lot of sense. So that combined with reducing the incidence of post-herpetic neuralgia really pushes me towards encouraging my patients, not just offering this, but encouraging this to people.
Yeah, and I love the way you
Give me
framed it.
four
Like
doses.
yeah, go ahead, Roger. Yes.
Give me 4 doses.
I love it. So what, I got this question the other day in the clinic from one of the residents. Should we eventually be giving people boosters for this? So that's a really fascinating, like, if there's this really potential dementia benefit, Shelly, do you foresee that somebody may be studying actually multiple doses of this in the future versus just this initial 2-dose series that people get?
I'm not too sure about that because what we know is that immunity from the new shingles vaccine is very long lived
Yeah,
as compared to Zostervax.
yeah.
So at this point, I don't see a reason for that, and I would not offer that to somebody.
Great point. Great point. Well, again, I love the way you framed this as almost like a 3-for-1 special here. Prevent zoster, prevent post-herpetic neuralgia, and maybe reduce your risk for dementia. So great discussion on that. So let me go ahead. Any other comments, anybody? Or Kristine, did you want to make any other comments on the shingles vaccine?
No, I was just going to comment that kind of that same idea is if we're switching the time to give the vaccine to 18,
Yeah.
I have had some patients express concern of, is it still going to work when I'm 70 and I really don't want to get shingles? So I think, again, that question of should we be giving boosters, especially if we're moving the dose to 18 instead of 50?
Yeah, and that question came up in the clinic in perspective, exactly what you framed. It was a person in her
Mm,
early 20s. And one of the issues is we don't see a lot of circulating zoster virus now because we basically have a predominantly vaccinated young population now. So the question is, are we getting all these micro inoculations like we used to when we were children and young adults? Are people now out in society getting all these sort of immune challenges? And is that going to be a relevant issue that people who really don't see any of this virus for 20 or 30 years or multiple decades would have booster dose beats? But it is reassuring to know from Shelli and from the data that's come out that there really does look like very good longer term. But again, we won't know till we get 20, 30 years out for some of these younger populations. So fascinating area. Let's turn to RSV vaccine. So this is a vaccine that I would say is maybe underutilized, and I'm not saying we should be using it a lot more. I just want to bring up what the recommendations are and let the audience sort of know where we're at with this. So a 62-year-old woman with HIV is seen for routine follow-up in September. She has a CD4 count of 186, but no other medical problems. So my question is, would you recommend vaccinating her against RSV? Love to see what the audience is going to do here. Okay, so we have 70% yes and 30% no. If you're looking what the recommendations are in the actual guidelines, the answer would be to give it. But I know in our clinic, a lot of other clinics, I bet if you did quality control looks at how much RSV vaccine is given, it may not be as high as we got in that audience response. And maybe for good reasons. But let me just turn to Chris for a second. When we have these respiratory viruses, where people become, severely ill with a pulmonary process, what's really the issue in terms of what potential death or hospitalizations, and how does this overlap with cardiovascular issues?
Yeah, love to address that question. I want to just step back though and say, especially with regard to zoster, but all of these vaccines, I think that we have an opportunity in our HIV clinics to really provide a level, higher quality of care than what we see in the general population. So even though for zoster, for example, we know that people with cardiovascular disease can get cardiovascular events when they have an infection, the rates of vaccination are 15-20% among all comers with cardiovascular disease. Whereas in the HIV clinic, you guys are so on top of things that you're providing a higher level of care than what we see in the general population. So just that overall comment. But certainly for RSV, we have evidence now. There's just 2 or 3 months ago a randomized trial in Denmark that showed that for people with and without cardiovascular disease, RSV vaccine was incredibly effective at reducing hospitalizations for RSV. Now, they also looked at cardiovascular events, and there was a reduction in cardiovascular events with the RSV vaccine, although with very wide confidence intervals, ended up not being statistically significant. But I think that the general recommendation is that we should be vaccinating people with cardiovascular disease to protect them from not only respiratory infection, but also from cardiovascular events.
Chris, thank you. Let me just briefly touch on what is in the guidelines. And just so that our audience knows, and again, I think this is, again, very useful to know for your pre and post test. I think the recommendation to immunize anyone 75 or older than 75 is not complicated. I think everybody can remember that. The age that I present in the scenario that I presented in this case was someone between 60 and 74. And surprisingly, that's actually not routinely recommended, but it is if they have a CD4 count less than 200, or they also have a comorbid condition that increases severity, like really bad asthma, underlying severe cardiovascular disease, something like this. And we're not going to talk about pregnant women because we're not talking about this, but as many of you know, this is now an available vaccine for individuals who are pregnant at weeks 32 to 36 is when they get that vaccine during that time frame. But let me just turn to Roger and say, this is what's out there in the guidelines. In Dallas, is this similar to what you do? Is this similar to what you've outlined to do? Is it completely different?
Thankfully not. It's not. We we have a lot to do to catch up to these guidelines, but I think that just like Chris mentioned, it's really important. We see this pandemic now going on in especially in this season. It's important for us to ramp up the coverage for this vaccine. And I practice in the VA where the median age is over 60.
Yeah.
So we have a very large proportion of our patients who might fall into the risk category for coverage for RSV, and we need to do better.
Yeah. So, how about Kristine? What about in Colorado? Are you using a lot of this? Not so much. What's your sense?
I've been using it a fair amount. I think I actually had more that were vaccinated. If I recall, the guidelines changed and it was at 60 and then they changed it to 75, unless I'm remembering that wrong. And so I had several that snuck in and got it before it changed to 75. Um, is that wrong?
Well, and it is FDA approved for people 60 and older.
60 and older, but they made
Yes.
I think they made the recommendations
So the
more
stringency.
more stringent for now or like the
Yeah.
75 and older.
Yeah.
So I think I've been somewhat flexible on the comorbid medical condition that increases the risk.
Yeah.
And so it's sort of a discussion with patients, those that are more, and I think comes back to the discussion we might have time for later, is kind of that balance of how vaccine hesitant people are. And, it's not one I necessarily push as hard as pneumovax for patients to get, but those that are willing to get it, we talk about the potential benefit from it. So I do generally recommend it. But I don't have a lot of people that have a CD4 count less than 200. So it comes
Yeah.
into that, does your comorbid condition actually increase the risk of severe RSV?
Yeah, and I would just say in Seattle, we're probably behind, sort of more like what Roger said. We're probably not following these, and I think part of it comes down to hierarchy of priorities. And by the end of
Yeah.
the day, after they've stacked up, trying to talk into doing this and that and a statin and blah blah blah, this just seems to be a little bit lower on the list. But I do want people to be aware of it and what the guidelines are that would back up if they are doing it and for insurance purposes. And Shelli or anyone else maybe want to comment. I know one of the hesitancies was when these vaccines first came out. There was, and there still is in two of the three out there, at least a listing and mentioning about Guillain-Barré following this vaccine. I don't know if anybody wants to comment on that, if that influences them at all, or if they've had patients wondering about this at all.
General, my approach to questions about Guillain-Barré and vaccines, because of course it comes up with other vaccines also, is to really target those conversations to people who have had, or maybe they've had a family member, or have had some personal experience with Guillain-Barré syndrome. And then we talk about what is the risk? Should we try a different formulation instead? And not so much in the general population. I would say I think I'm also behind on RSV vaccination, speaking honestly. I
Yeah.
usually think to offer it to my very oldest patients, so those over 75 or those who have a chronic lung disease. Even though that's not the way the guidelines frame it, but that's kind of how I've been approaching it. But you're right. I think we probably all need to be thinking about this more often.
The only other kind of curveball I throw in there is that I've seen from different angle is that I think a lot of us who have older patients who may be around new children, I think the RSV vaccine's been much more widely
Yeah.
uptake. There's been a much wider uptake in sort of the OBGYN community. And so I think people are going to be around small children and newborn children. There's actually, I think, some interest in immunizing these older individuals, sort of like getting a Tdap vaccine, and you're going to be around grandchildren and so forth. So sometimes that's a question that you may get, or parents may come in, or grandparents may come in with that concern. I do want to mention there's three of these vaccines that are out there now, and they're all FDA approved for people 60 and older. And they all can be used people younger than that if they have an increased risk. So back to Kristine's point, these have been FDA approved for people 60 and older. And this risk of Guillain-Barré is very small, but it's, on the order of, between 5 and 10 people per million doses. So very low risk, but it's out there. It has not been seen with the third vaccine, which is an mRNA vaccine, but that vaccine does not have nearly the post-marketing numbers and data. So we don't know for sure, is that really truly uh, zero risk for Guillain-Barré. But again, very low risk. You'll see people ask about it. It is on the order of, 5 to 10 people per million doses. This isn't like, one out of every 5 people getting it. So those are the three. Those are the recommendations, and that's what's approved. Let's switch to the flu. Okay, so let's see what people are doing about this. 66-year-old man with HIV comes in for a routine visit. And the question, it's in the late fall. He's not received a flu vaccine this year, and he would like to get a flu vaccine. So the question is, do you recommend giving a different flu vaccine to your patients with HIV who are at least 65 years of age than you would be, say, for example, one of your 30-year-old patients? Would that be a yes or no? And again, love to see what the audience response is going to show here. Okay, so a lot of people are. That's great. So if you actually look at what the guidelines are saying, and again, I'm not sure we're all following the guidelines as strictly as we should, but briefly just to mention what the guidelines say on this is that the actual OI guidelines are recommending this. And maybe Roger, I'll turn to you and what do you think about the guidelines recommendations? Are you doing this? Do you pick a different flu vaccine, or is it just logistically too complicated to do it?
Yeah, and again, we are at the cutting edge of aging in the VA, and so we're very sensitive to this particular issue, and we use this high dose recombinant vaccine for most of our people who are older than 65. Like I say, in population of people with HIV, the median age is just about that now. So we have to be more sensitive to this, and I think that
Yeah.
the immunogenicity in that age group for the high dose is better.
Kristine, what about you?
Yeah, we're routinely using the high dose in 65 or older. And luckily, our medical assistants are really on top of this. And if I accidentally order
Yeah.
the regular one, they're correcting me and changing it, which has been great. So definitely giving the higher dose for our older patients.
That's great. And I do want to underscore that point. So specifically, if you're ordering Fluzone, there's a regular Fluzone and then there's a high dose Fluzone. And the high dose Fluzone has about 4 times the amount of antigen in it. So you need to be exactly as you just said. For everybody in your audience, you need to make sure if you want the high dose Fluzone that you specifically order that. Chris, can you comment a little bit on, flu is, we look at the numbers every year. There are a lot of people that die. Why are they dying? Are some people dying from cardiovascular complications? And what is it about getting influenza that would make you have a cardiovascular event?
Yeah, absolutely. So, flu vaccine is actually the only class 1 recommendation from the American Heart Association for preventing cardiovascular events in people with cardiovascular disease. The Europeans kind of take a broader approach for other vaccines. But yeah, absolutely, people are dying of MI. It's that going back to systemic inflammation and acute inflammation, kind of increased thrombotic risk around the time of the flu. And so absolutely, we should be vaccinating our people with cardiovascular disease. There was a recent trial in Denmark that compared high versus low dose flu vaccine and looked at cardiovascular events. And there was no difference in cardiovascular events between the two. Obviously, the high dose vaccine was more effective in reducing flu events. But regardless, please, this is the #1 most important vaccine for people with cardiovascular disease.
Great. Thanks for bringing that up. And I do want to ask, because it sounds like even maybe without severe hypoxemia, there could be this inflammatory and prothrombotic state that people could be in. But in more severe lung disease, does hypoxemia also play a role in someone with, I'm assuming it does, but is there, is that the general pervading theory?
Yeah, it's all of the above. But we can see type 1 myocardial infarctions, but we also get demand infarctions when people get real sick. So
Okay.
Yes, all of the above.
And Shelli, I'm going to turn to you. We have, I don't know if other people experience this. We have some people come in our clinic and we'll go down a list of vaccines, pneumococcal fine, mpox fine, blah, blah, blah. And then we say flu. I don't want the flu shot. I don't want the COVID shot. And they die on the flu and the COVID hills. And I just would say in your clinic and on the, thinking about this on the East Coast, do you have some flu shot hesitancy And as Chris is saying, this is a really important vaccine, and it's so easy, it's so accessible, at your clinic, at your pharmacy, everywhere you go. So, what's been your experience?
Absolutely. And it's a new phenomenon in my experience that I see now in the post-COVID vaccine era. So
Yeah,
prior to COVID, it was rare for me to have somebody who had an objection to the flu vaccine.
yeah,
But post-COVID, you're right that it seems to be lumped into the same um, hesitation or feelings that people have against the annual COVID vaccine. It's
yeah,
a tough one, and I try to use it as an opportunity to, I don't know if harm reduction is the right word, but choose one and go with it. And my
yeah,
recommendation to them is I actually think the flu vaccine is more important for you. And that's the one
yeah,
that I talk about them getting. And I say it's fine if you don't want to get the COVID vaccine this year, and we can talk about
yeah,
that. And but my recommendation is to get the flu vaccine because in older adults and people with comorbid conditions, you're more likely to have a bad outcome from the flu than you are from COVID-19. And I think being honest about that, some of my patients appreciate that.
yeah.
Mhm, mhm.
Yeah, I like that approach. Anybody else want to add anything to this? Definitely, we've seen a lot of this in Seattle. Some before, but definitely a lot more flu hesitancy than we did in the past. Any
Yeah,
thoughts?
vaccine hesitancy is a post-acute sequela of COVID. And since COVID, unfortunately, it has become a broader issue. And picking our battles has become maybe the the best thing that we can do because, of course, mandates uh, no longer do exist for many of those, and we have to offer. And so, like Shelly, I say, take the flu shot if there's no objection to that. And especially with people with comorbidities, please consider the COVID, RSV, and then we'll do the best. I don't challenge
Yeah.
pre-assumptions.
Yeah, I appreciate both of your comments a lot on that. And I would say my experience has been your chances of changing someone's opinion and their willingness to do a COVID vaccine is close to zero. But the chance of discussing flu or RSV or pneumococcal or
Mhm.
meningococcal, people are more likely to listen and you have a better chance. So I
Mhm.
definitely appreciate both of your perspective on that.
Yeah.
Kristine, do you want to comment on that? And I know this is a really big issue, and we were going to talk about it a little bit more, but just because it comes up, and flu is such an important vaccine, any comments or thoughts you want to share?
Yeah, I think similarly, I've had less
I think
people
you're on
willing.
mute for,
Oh,
yep,
No,
uh,
no, shit. No,
no.
I can hear you.
Okay. I
you're
think
still
I've had,
losing your audio,
can others?
I can hear you
but it
just
looks like
fine.
you have
Okay.
something really
Okay.
good to say, but I just can't
Okay.
hear you.
I think I've had more people that are willing to get or fewer people that are willing to get the flu vaccine, but I also am surprised at the number who come in and I want the flu vaccine, but I don't want the COVID vaccine. So I think
Yeah,
I have seen, I think there's a comfort with the flu. It's been around for so much longer. It's not this new mRNA that people may be
yeah,
concerned about. So I think that there is a little bit more comfort with flu than COVID, at least in a lot of my patients. But the COVID vaccine, I think, is the one that raises those concerns. I think people don't tend to have as much of side effects often with flu as well. And so they're maybe
yeah,
more willing to get that because
yeah.
they've gotten it for so many years and are comfortable with it and know the side effects.
Yeah, great point. So, for everybody for our audience, yes, I think everybody's very pro for using the higher dose influenza vaccine. We've heard from Chris the extraordinarily high priority from cardiovascular and from the American Heart Association on this vaccine. We've all shared difficulty in getting people to do this. We want to distinguish, make sure we're not lumping this in the same with COVID and being able to offer this in people who may be hesitant because of COVID vaccination or concern about COVID vaccination. So all great points. Thank you. All right, let's turn to Mpox. Now, why are we talking about Mpox in older patients? Well, it comes up, and I think in our clinic, our age distribution is for people developing clinical Mpox is predominantly under the age of 50, but we've definitely seen people 50 and older concerned about wanting to get Mpox vaccine. So there's a really important issue that comes up. So a 59-year-old man comes in. This is a case for everybody. is seen in the clinic with urethral discharge, diagnosed with gonorrhea. The Mpox cases in our area have increased in recent months. And at this visit, you discuss him getting the Mpox vaccine. And just to clarify, I'm talking about the Jynneos vaccine, which is the currently recommended one. So he reports that he had smallpox vaccine as a child. So the smallpox vaccine that most people got as a child was called Dryvax, and that was the one where they jabbed people multiple times in the arm, and you actually developed a pox and a scab, and he remembers that. So the question I'm asking now is, does he need Mpox vaccine if he got vaccinated against smallpox as a child, or does he essentially have lifelong immunity? So what does the audience think? No Mpox vaccine, give 1 dose of the Mpox vaccine, or give 2 doses of the Mpox vaccine? Okay, I like the response. So the correct answer for this, according to guidance out there, would be to give the 2 doses and that to consider this person at this point probably not immune. It is a great question. And there's a lot of theories out there about why maybe we didn't see Mpox emerge earlier from sexual transmission and from the Europe and in the US. And there was some belief that maybe a lot of the population in their 30s and 40s and 50s had partial immunity to Mpox based on the smallpox vaccine that they got as a child. So according to guidance, you would go ahead and offer if this person had an indication, and clearly they had gonorrhea, they're interested in it, and I think this is reasonable. So just to make sure everybody knows the recommendation, if somebody got a smallpox vaccine more than 10 years ago, which is really what we're going to be talking about in our older population, the current recommendations are to actually go ahead and give 2 doses of Jynneos, just like most people in the audience suggested. I am using a trade name here because the ACAM 2000 is not what we should be giving people with HIV. That is a live smallpox vaccine that is not recommended for our HIV community. We should be using Jynneos if you're going to be vaccinating against Mpox. So, this is one of those things where smallpox was theoretically eradicated in 1980, and then it was really only available in emergency stockpile. So let me just reiterate that the Mpox vaccine is 2 doses given at least a month apart. And then what I want to turn to the panel to ask about are these 2 questions. So Roger, I'll turn to you and see what you think about this. So in your clinic, and this comes up, so would you give Mpox vaccination for someone who previously had a diagnosis of Mpox, and they go like, I don't want to get that again. And what about are booster doses recommended? So can you tackle both of those?
Yeah, so I mean, the number one is that somebody who already has Mpox is quite exposed, and it's not clear that they develop a sufficient protective and lifelong immunity from that exposure. And so that's that's my take, and correct me if I'm wrong. And so I think that I would, again, not during the acute phase, but I would consider immunizing that person.
So this is fascinating because this is one of the most controversial issues, and I just want to mention what's in the guidelines, but I'll turn to the other panelists as well and see what they think. Sorry, in that the current guidelines actually don't recommend giving a booster doses and in previously been vaccinated, but in our clinic, this is probably the most controversial issue out there because I know some other countries and places are actually giving booster doses for Mpox. So I don't know if anybody else on the panel wants to comment on this, but Roger, I appreciate your comments because it'd be interesting to see what the audience what may come up in the Q&A if they're doing this. But there's a lot of controversy around this, and that's why I threw those 2 questions in there.
Yeah.
Yeah, I don't think we're reboostering, at least as of right now. I mean, if we still have Mpox in 10 years, that may become a different issue. But I think right now we're not reboosting anyone.
Yeah, and the arguments pro and con have been, there's definitely people who have become reinfected, who've had previous Mpox. There are definitely people who've had Mpox after getting vaccinated, but the number of severe illnesses have been low. So there's this tension or sort of controversy about it. And Roger, I don't know if you want to add a few more comments too.
No, I think the immunogenicity of getting an mpox is tends to not be
Yep.
durable or the same as the vaccine. But I agree that the severity of the infection is not going to be there. So I understand the discrepancy between the U.S. and other countries'
Yep.
guidelines based on that.
Yep. And I'm wanting everybody, encouraging everybody to keep following these recommendations and see if they change over time as we get sort of more time out from that huge pandemic that we had, or the
Yeah.
European US mpox, where we had the huge number of cases. All right. So that was just a brief thing. Now, let's turn a little bit to kind of the last 10, 15 minutes, talk about some of our kind of opinions about strategies and things that we do. And I'd like to see what people think about this. So 61-year-old woman comes into the clinic. She's newly diagnosed with HIV. She started on dolutegravir taf FTC. Her initial CD4 count sort of lowish, 262. So I guess the question I would have is, she's a new patient, and Shelli, I'm going to turn to you first. Let's say she came in and saw you. What strategies would you have? Number one, just like, how much would you prioritize vaccines that first visit or two? And then after that, can you talk a little bit about maybe what would be your what you practically might do in a person like this? Any vaccines, one or two? Which ones, if you do it?
Yeah, so I mean, right off the bat, we need to know if she's been immunized against hepatitis B, of course. So that would be kind of a low-hanging fruit to just through blood work understand. But in terms of prospectively giving vaccines, I do prioritize pneumococcal vaccine in new diagnoses because we know that people with HIV, and especially those with low CD4 counts and those with impaired T cells, also have impaired B cells and impaired antibody responses. And so they are at risk for invasive pneumococcal disease, which can be deadly. So that's kind of, I would say, a very top one for me. And if they only want to get one, that's probably the one that I would do. Probably depending on the season, influenza, for all the reasons we talked about today. And actually, what Chris said about cardioprotection is going to be something I'm going to talk more about with my patients moving forward. So that's really helpful. Um, shingles can wait a little if needed because those other two I think are more important in terms of getting them in faster. Um, and COVID is low on my list again for the reasons we talked about earlier, and also for I think establishing rapport. I'm not sure that that's the thing I want to get out right at the first visit.
Yep. Yep.
So unless I'm missing something super important, that's how I would start.
That's great. I'm going to actually look to everybody to make a comment, 'cause I think it's a really
Yeah.
important sort of clinical approach, and it's very individualized. So, Roger, if you're seeing someone new like this, would you even give them anything the first visit? If you do, again, sort of, what would you prioritize?
Yeah, I would offer. And my take is at this age, what's gonna kill you? Pneumonia is this, like Osler said, is the friend of the old because he comes to take them home. And I think that the mortality from invasive pneumococcal disease is so much higher that that's what I would prioritize, in addition to influenza for a number of the reasons, including the risk for kind of metabolic risk. So I would offer those two and then make sure that I know the uh, hepatitis serology
Yeah,
and see if they can get hepatitis or they should get hepatitis B. Yeah, the rest I can see. But again, I want to tell them that so far I don't see a significant risk for concomitant influenza administrations. Patients would be asking about that, if you gave me all these jabs now, we're gonna make it sicker. And I think that or that there's any interactions with the antiretrovirals that they're receiving. And I'd like to allay the concerns about those two potential concerns and see if we can convince them to take maybe influenza and pneumococcal immunizations first.
great. Kristine, I'm going to turn to everybody. I'd love to see what everybody, what's your approach?
I'd want to know, well, first, is she starting therapy today or she's been on it and she's following up?
She's starting it today.
She's
So
starting
she's
it today.
just going
Okay.
to be
So
starting on it.
yeah, I think some of it again is coming, like, is she willing to get vaccines today? Because if she
Yeah.
says no, I don't want anything today, then I'll drop it and talk about it at the next visit because she's got a lot. We're throwing a lot at her today. So I think that would be my initial approach is can we talk about vaccines? And then I'd want to know a little bit about potential risk factors. Like, is she high risk for tetanus? Does she have kids at home or grandkids
Hmm.
at home? Things like that that may push me more towards giving her a Tdap or some of the other kind of RSV or some of those risk associated ones. Does she work in a micro lab? Like things that we that
Yeah.
might change our push for meningococcal or some other ones we might not necessarily push up front. But assuming none of that, then similar to Shelli and Roger, I would push flu and pneumococcus as my initial two, in
Yeah.
particular if we're going into respiratory virus season. If it's
Yeah.
May,
That's great.
maybe
That would be
not,
my
but
short
yeah,
list as well too. I
yeah,
love that. So,
yeah.
Chris, now let's say she had some cardiovascular. So Christine's bringing it up. Let's say if we knew a little bit more about her and she really, she maybe had an MI 3 years ago or she had angina, and we're looking like, where do we get our most bang for our buck with vaccines for cardiovascular? I think you may have already answered this, but what would be your thoughts on prioritizing someone like this?
Yeah. I mean, I think it's the flu and the pneumococcal vaccine, like everyone else has said.
Yeah.
I don't know that I have any more expertise to add, other than I would probably consult Dr. Spach from across the room in clinic.
We work in the same clinic, so it's great. We're curbsiding each other, so it's great. I do want to ask one more question, and Roger, I'm particularly interested in yours. Do you think let's say she said, "Okay, I'm a little bit overwhelmed, and I want to wait to my next visit, and let's say you're going to follow her up in 3 or 4 weeks. Could there theoretically be any advantage of just driving her viral load down for 3 weeks and getting maybe a better immune response to some of these vaccines? Maybe let's disregard flu, but let's take some of the ones that we're really going to be we get our shot with it, like pneumococcal vaccine, maybe those initial meningococcal, whatever. Are there any vaccines, hepatitis would be, let's say, and
Yeah.
let's say we already had our serology. Is there any time that you think, oh, I just would love to have the viral load down a little bit before giving these?
Yeah, more than the viral load. If CD4 count was 50, I would say some of the immunizations maybe they may not respond as well, and if the risk is not high, hepatitis B comes to mind, I can try to wait. But in terms of the viremia itself, I'm not certain that, of course, the immune activation itself is significant with on suppressed viremia, and that may or may not interact with things. But I would plead ignorance on the viremia part. But in the CD4 counts, they could be rational.
Fabulous. Anybody have any other thoughts on that? I love that
Well, Dr.
response.
Spock, I'm actually wondering because I do the same thing as Dr. Bedimo. If someone has a low CD4 count, I wait. But I don't
Yeah,
know that everyone does, and I don't know that it's the right thing to do. So I'm kind of wondering what your practice is. If you had a
yeah,
new diagnosis with the CD4 count in the 70s, are you
yeah.
waiting to give pneumococcal vaccine or are you giving it at that first visit?
Okay, I will tell you what the guidelines say that with the newer conjugate pneumococcal vaccines, you do get very good immune responses, and the guidelines say you can
Yes.
administer it. What I do is that if a person comes in and they're overwhelmed, I'm hesitant to give them a lot of vaccines the first visit, but I always make sure they have a follow-up visit in 3 or 4 weeks. And I personally, for someone with a pneumococcal vaccine and they have a really low CD4 count, it's a one and done. So I
Yeah.
like the idea of having them on antiretroviral
Yeah.
therapy for 3 or 4 weeks and then giving them that dose of pneumococcal. I used to be less with pneumococcal PCV13 where the same
Hmm.
Mhm.
recommendation existed, but you're going to keep
Yeah.
giving them more
Yeah.
vaccines.
Yeah,
Yeah.
I just am a little nervous about that sort of one and done, giving them,
right.
and because we have some data, but it's mainly extrapolating from PCV13 and immune responses.
Yeah.
So
Mhm.
I personally do that, but some of
Yeah.
it is honestly, I sometimes see people coming in that first visit and they're so overwhelmed that my priority number one is develop a great rapport so they want to come back to the clinic. And
Yeah.
number two, get them on antiretroviral therapy. And then the vaccines would probably be overall my priority three, but clearly offering something like seasonal influenza if the time was just right.
Yeah.
I wouldn't wait for influenza. I don't know if anybody would wait with a lower CD4.
Yeah.
They come in
Yeah.
October. Roger, would you wait with
No,
influenza?
no, I wouldn't. And I just like you, I kind of will look at that person who's coming in overwhelmed, and there's a lot of social factors,
Yeah,
antiretroviral, getting used to them, and turning them into a pincushion that first day is not conducive to good relationships in the
yeah.
in the future. So I would try to have fewer jabs.
And I've seen some people ordering the very first visit, like a COVID vaccine and zoster vaccine the first visit. And the last thing I want someone to do is feel horribly sick the day after they come
Yeah,
into the
Yeah.
clinic
yeah, yeah.
and not want to come back. So those are two vaccines that I, in particular, would try to defer unless they really wanted to get a COVID vaccine at that visit. But great comments. Now let's turn back just for a second to meningococcal vaccine. So this is just a real quick sort of question, and just to clarify for our audience and make sure that we're all doing this correctly. So, 53-year-old man, they're seeing a follow-up. He's been receiving quadrivalent meningococcal vaccine every 5 years. His last dose was 5 years ago. He's ready now for another dose. So the question is, now that we have more options for meningococcal vaccine, what would we give this individual who's 53? Would we give him meningococcal B vaccine, the quadrivalent conjugate meningococcal vaccine like you've been giving, or would we give the new pentavalent conjugate meningococcal vaccine? What do you like here for your choice? Okay, these are really quick responses. That's great. So for the audience, the correct answer here would be B, the quadrivalent meningococcal vaccine. I just want to make one very brief teaching point about this. The pentavalent meningococcal vaccine has the same four serotypes in the quadrivalent, but it adds in meningococcal B. But as a reminder, everybody, meningococcal B vaccine is a priority in younger adults, end of high school age, early college age. That's the priority. So a 53-year-old, there is no recommendation anywhere to be giving them meningococcal B vaccine. So newer isn't always better. And really you would just stick with the quadrivalent meningococcal vaccine. So I just want to make this point because some people are changing their formularies. Some people are using pentavalent conjugate meningococcal vaccines now. And I want to make sure people know that's not the regular recommended. Roger, have you seen this mix up at all? Or you've
I totally agree. And I think that it's important to clarify that to providers. There could be some caveats when of non-college age people could be at high risk, asplenic individuals, people with complement deficiency. I mean, with HIV could come other things. So if you have asplenia, maybe that's a
yeah.
consideration for covering the waterfront, but not in the routine care of the person with HIV.
Kristine or Shelli, any comments you want to make, or Chris, anybody want to make a comment on that?
Yeah, I was just going to comment on the asplenic patient that I would give B to, but that would be the exception.
Okay, great. All right, so this is the current guideline recommendation. And I would say if you were to probably do, again, sort of a quality control, I would say most clinics are not great about giving meningococcal vaccine every 5 years. That is the recommendation. I will also say, in fairness to clinics and to providers that are not doing this, honestly, the risk for meningococcal disease is probably higher in younger age. So as people get older, at least in the HIV community, the risk has been generally in younger adults. So anyway, I think this is what's out there. That is what's there. And also just for you to know, in case you've ever read, oh, you can't give these, quadrivalent meningococcal vaccines to people 50 and older because they're off label, that's fine. All the guidelines recommend you continue doing this. There's no age limit on the guidelines for when you give meningococcal vaccine. So I just want to, and these again, some of these slides for the audience, some of these I'm not spending much time on, but they're really kind of as a reference point for some of the points that the audience and we've been making, or our panelists and myself have been making, that you have this as a kind of a reference point after the panel today. But anyway, these are the list of all the different ones, but the meningococcal pentavalent vaccine is not what's recommended for the routine immunization. Okay, so I think we're right about on time. Let's go ahead and take a few questions now.
Yeah, while we're on meningococcal, there was a question about whether meningococcal vaccine is recommended for females, if there's a difference for sex or gender, as there's been some note that it has been lower priority in females in some populations. So any comment on the risk and who you would prioritize for meningococcal besides the younger age that you mentioned?
Do you want me to take that or someone else take it? I'm
You
happy.
can take it if you want,
Okay.
unless someone else wants to.
And I'll see if anybody else has a different take on it. I would
I don't
say
see too many women at the VA.
yeah. The guidelines don't differentiate by sex gender, but they do make a uniform recommendation. If you look at the data, the highest risk in HIV have been in men who have sex with men from an epidemiologic standpoint. So if you were going to prioritize, that's where I would prioritize. Um, and again, I think thinking about vaccines and priority, if you're trying to negotiate, and in an ideal world, we give everything that's recommended to everybody. That just doesn't happen in the real world. So I think a question like this is a really good question because from a practical standpoint, it would be, lower priority in a cisgender woman who's 60 years old for sure than a 30-year-old man who is, actively having sex with other men. I think they're two different situations.
Yep. We had a couple questions on RSV, and I noted on your approval, it is approved, I think, for 18 to 59 if at risk for lower respiratory tract infection. And some people noted that their electronic medical record triggers for people age 50 and older to give the vaccine. So, what's the recommendation? Who would you consider giving the vaccine to if they're in that 50 to 60 range, that aren't even in the 60 to 75 range?
Roger, do you want to take that? And I'm happy to add on to any comments you want.
No, I'll let you take it
Okay,
on.
so the bottom line recommendation is that um, it's interesting in that sort of years ago when we think about like how we gave influenza vaccine, it's a
Mhm.
really simple recommendation now. For all the newer clinicians, it's like, okay, you don't even need to think about it. Just anybody walks in, you say, okay, we'll give you a flu shot. But I remember the years of practicing, and those of you who are, older than 50 years of age can remember when we had to go through a long list. Did you need, you're 40 years old. I would say RSV is like that. So people who have, for example, severe asthma, people with underlying severe cardiovascular disease, transplant patients, you could make that argument. Now, HIV has not been lumped into that, except for, again, the guidelines saying people 60 to 75 who have a CD4 count less than 200. So I would think out in clinical practice, it's a lower priority vaccine, but it would be for people who have significant underlying medical morbidities. And I would say, for example, people like, people with renal failure and on dialysis would probably, I don't know that list, but it would probably be in my mind would make sense, people like that. The main thing would be people who have high risk of complications from lower respiratory tract disease. So big cardiovascular risk, big pulmonary risk would be the two things that I would focus on.
Mhm. Great.
And then also just to remember that pregnant individuals,
Yep.
they are certainly able at any age they're eligible for it in week 32 to 36 in pregnancy.
There was a comment, a patient that avoids getting flu and COVID together because of an increased risk for thrombosis with a combined vaccination. Any comment on whether that's a legitimate concern?
Chris, since that's somewhat in the cardiovascular range, do you want to try to tackle that?
I actually don't know the answer. I'm not sure if you do, David.
I know there's an
Not
increased
aware.
risk of thrombosis with COVID.
That's for sure.
Less,
Yeah.
yeah.
And I'll just ask all the panelists. I have personally not heard of an increased risk with influenza vaccine, and
Yeah.
I've not heard of an increased risk with influenza combined with any other vaccines, but I'm not aware if anybody else has heard that.
Mhm.
I think we probably would have heard it if there was a signal
Yeah.
for that.
Mhm. Yeah.
So I'd be comfortable saying, yes, I think there is a very small risk with COVID vaccine that's real, but a very small risk. Not
Yeah.
as high a risk as the disease itself, but there is real. But I don't think any of us have really heard that with influenza.
Yeah, the Johnson vaccine and maybe the AZD, whatever they had a higher concern for that. That's why they're not used much in the US. But I don't know about the mRNA ones.
Yeah.
I know that it's in fashion to shoot the mRNA messenger, but that's not something that he
Yeah.
did.
A couple questions on the Jynneos and kind of counseling for Mpox. In considering lower risk regions or lower risk patients, potentially those that come in that have been in, stable relationship, aren't sexually active, who are you counseling and in what regions do you really push the vaccine in, if there's lower risk areas of the US right now?
So I would say there's two things that clinicians should really think about. And one is what is, as you're referring to, the underlying risk from people. And I would say it's sort of very similar to what we think about with, concomitant risk where they've had active sexually transmitted infections in the past year. They're having sex with multiple partners or group sex associated with concomitant, drugs or methamphetamine. Those are going to be our highest. And clearly, men who have sex with men, if you look at the epidemiology, that is by far where we've seen the most cases in people with Mpox. So I think that's the first factor. But honestly, I think what happens in the real world too is that you're looking to see what's happening from a national and regional epidemiological standpoint. And I just know that in our clinic, there'll be like a big lull and nobody's getting Mpox vaccine. And suddenly you hear about 10 cases in the community and suddenly everybody's running in
Yep.
to get Mpox. So I tend to put both of those together. And I do think it's a big, it's great if people can proactively do it, but I think the motivation is so much higher when people hear about cases in their community. And Roger or Shelli, if you want to comment on that as well too, it'd be great.
Oh, thanks. That's all right.
It sounds like they're happy with that answer. So excellent. Well, I think we're at time. So I apologize for the questions that didn't get answered in the chat. Thank you for the very engaging Q&A session. Please keep this up for the next session, which will hopefully be just as engaging. We will return at 35 minutes after, so about a 14-minute break. So please feel free to hang on the Zoom here and come back in about 14 minutes to hear about frailty. Thank you again for hanging out with us today.
And thank you all the panelists. That was great. You did great. Thank you.
Thank you
That
so
was
much,
fun.
Dr.
Thank
Spach.
you.
Terrific.
Thank you.